what's the difference between analgesia and anesthesia? Well, we talked about analgesia, right? We talked last two sessions that kind of focused on that. So analgesia is specific inhibition of pain pathways, actions on specific receptors and primary nociceptors and in the CNS. So we talked about peripheral versus central. Local anesthesias block voltage-gated sodium channels and non-specific inhibition of peripheral sensory motor and autonomic pathways. So we'll talk about the locals being more than the local anesthetics are sodium channel blockers. When we talk the inhalation and general anesthetics, that's a little up in the air. They don't know the specific mechanisms, but it hovers around GABA. It also involves the NMDA receptor, stuff that we haven't really talked about and focused on. So I'll give you an overview of it, but we're not going to go into the details of NMDA. Inhibits conduction of action potentials in all the afferent and efferent nerve fibers, usually peripheral. Pain not transmitted to brain, motor and autonomic impulses not transmitted to muscles. With the locals, they have a tendency to focus more on the small nerves first. So at lower concentrations, you'll get the smaller nerves. We'll talk about what that means, the different types of sensation, temperature, touch, pain, and then as you continue to increase, then you get motor. For the most part, what you guys need to do and what you will be doing doesn't require that higher dose, does not require that higher concentration. So you're not targeting the motor, you're targeting the sensation.
So,
Yeah.
analgesia is general?
No, so analgesia is pain.
Okay.
Okay? As we talk to anesthesia, we're going to talk to loss of sensation and touch, and we're going to go beyond hypnosis. And when we talk to general, it will be the verge of coma. Okay? And we'll talk about the breadth of it in a minute. I wanted to just kind of separate the two right off the bat because we've been talking so much about analgesia. So local anesthesia. So we're going to be talking about blocking the pain. Loss of sensation is limited region of the body. We try to limit to the target organ. So for those of you that may be doing TTEs, we do not allow, they're not typically awake and alert. They're able to respond sometimes, but you're going to be using different types of drugs. Some are going to be local. You may be using sprays. I don't know. Yes.
When are they going to keep somebody awake enough to respond for a TE?
So are they able to, have you been present for TE?
Yeah, a lot.
Okay. Transtracheal,
Transesophageal.
transesophageal.
That goes, that's like a probistic down the throat.
Right, sleep, this big one, ultrasound. So let me ask you this, you ask the patient to cough, can they cough?
No,
Swallow?
they're toast on propofol.
Okay, so propofol has multiple layers or levels. So you can, and they're probably on propofol and some type of benzo.
Yeah. They flush them out real good, get them loopy, and then they hit them with the propofol.
They're able to breathe on their own?
Sometimes. I've seen
You ever hooked them
quite
up
a
to
few bagged. No, I've never hooked up
Okay,
to
so
them.
they've gone,
They just
they've
bag
gone a little
them.
too far, if you're bagging them, right? I will tell you for a cath, like a angiography, I would think for a TTE, I would have to, I don't know the answer right now.
Yeah.
That
I was just curious.
Yeah, that they wouldn't snow them to the point where they require ventilation or any type of.
Yeah, I mean, that was two cases where they weren't planning on having to bag them. But
It went a little far.
yeah, I've just never seen them even remotely conscious.
So if you ask, well, you see there's a difference. If you ask them, can you please cough?
They talk to them. They make sure that they're unresponsive before they even put the probe in their throat.
Okay.
They swallow for us.
Really?
They'll swallow when they're sore.
So that's what I was
That's cool.
expecting. I would have expected that they would be able to respond to commands, but
Some
not
of
know where
them
they
will
are.
wait till they're all the way out, but then there are two specific doctors that don't wait. They kind of like to coach the patients through, but then a lot of times they're gagging and, you know.
So the gag, you can eliminate the gag with local anesthetic, right? So spray, the benzo will help them, will relax them, and then propofol will will put them down. Propofol has no analgesic properties. So it doesn't do anything for the pain, nor does the benzo, the lidocaine will block it, the benzocaine or whatever they can use. So most of the time, they're able to respond, and that's why they do it.
That's cool.
And it's the same thing if you're ever in a cath lab and you're watching angiogram. I've had it done several times, and I don't remember any of it. But I will tell you that when I used to be in the cath lab, one of the things that we would do is when we push the dye, we fill up the heart in order to see the ventricle and measure cardiac output and look at wall motion. What you ask them to do is cough, because by coughing you push the dye out quicker. Because if not, you've included all the coronaries with dye in the blood. So as unconscious as they may seem, they're still in the follow commands. Just gave you some examples of, and this is for your own application, I'm not gonna spend a lot of time on this, of different routes. You're gonna see this used different ways, different times. And I thought I would do this because when people are talking to me, I always want to know, so what does it mean to be topical? I think everybody knows that. Well, what is intravenous region? So injection of local anesthetic in the vein, the method also known as a beer block, that is used for brief surgical procedures of the extremities, versus peripheral. So you're targeting a larger section of nerves to treat the acute pain. Epidural, most people are familiar with, where it's directly injected into the epidural space and it's going to coat and flood the central CNS and spinal cord, and you get the spinal injections into the spinal fluid or subarachnoid space. So this is for you. This is definition, so that when you hear someone talk, you understand what they're trying to do. Okay. So this is where I'm gonna probably give you a little bit more information than you want to hear. So welcome to Monday morning. Happy to have a chat about the mechanisms of action of local anesthetics. So this is a big thing for me. So I'm gonna let you know that right off the bat. It
Wait,
is-
before you go.
Yep.
Okay, you're gonna go on a long one. Can you do your very best to speak it in simple terms?
I will absolutely keep it short and direct. How's that?
And said a little louder too.
And
Okay.
word it like that on
A
the
little
test
louder.
too, simple.
Yeah.
And.
Yes. And one more. Okay. So a little louder, short and direct. How's this? Local anesthetics are weak bases. So only unionized local anesthetics are able to have an effect. Unionized. And the reason is that it has to traverse the membrane. So it's got to move through the channel in order to be able to work. It works from the intracellular side, not the extracellular side, okay? So what happens is that when an area is more acidic, these weak bases are they're charged, they're ionized. So because they are ionized, they are less effective. Make sense? So weak bases in an acidic environment are more ionized. If they're more ionized, they cannot traverse the cell membrane because these drugs work from the inside. They actually they bind to the inside of the channel and block it from the intracellular side. So when they're ionized, they cannot get through the membrane. Why, when you have a toothache, you have an abscess, does it take so much more lidocaine to numb the area? Have you ever noticed that? Has anyone gone to the dentist and they may have had a cavity or an abscess and they're like, still feel it, still feel it.
Inflammation, increased blood flow, more acidic area.
Inflammation, not necessarily the blood flow, but inflammation leads to an acidic environment, and because the pH is lower, the lidocaine is not effective. Okay? That's what all of this says. How's that?
That was good, but it actually was.
But.
Well, no, this is just a question on it. So, because it's an acidic area, base can't get through to the intracellular.
The anesthetic can't, the local anesthetic can't, right? It cannot, so, you know, this is gonna be a little tangent, now that I give you the direct version. So, it's logarithmic. So what I mean by that, at 7.4, you're probably pretty close to 50-50, even though, because it's a weak base. But at 7.3, that means 90% is ionized. At 7.2, 99% is ionized. So for every 1 drop, 0.1 drop in that pH, you have a logarithmic move in ionized versus unionized. It's log versus protonated over unprotonated. So my point is that when you have a bad infection, then it's gonna take a lot more drug. That's when sometimes you might be looking at other alternatives, other ways that you might want to induce the anesthesia.
So as the pH drops, the ionization increases.
Yep. And I would say that's for like 99%. Now, what they can do is that they can mix, they can put in different bases or different compounds, so they can change the actual, the acidity of the compound, making it a neutral or a weak acid versus a weak base. But the majority of the time, what you're getting is a weak base. Yes.
Okay, so you inject a bunch of lidocaine into the abscess. It's not getting absorbed, or it's not
And let me be clear, not into the abscess.
near the abscess.
Right.
Um,
But you don't want to do that, because you wind up with bigger problems.
Okay. If it's not crossing the cell membrane there, where is it going? Like, why is it not gonna affect any
Into
other part of the
circulation,
body?
it just gets,
Just gets
well,
done.
toxicity can ensue.
Okay.
But it requires a whole lot of drug for toxicity for the local anesthetics, but it can happen.
But it's not crossing any membrane.
Nope.
Okay.
And Dr. Lord, can you go over that pH numbers again one more time?
So, and this is only for your edification.
Oh, I thought you might be able to.
No,
No.
Give a
no,
pH.
nope. I'll keep you to this. Is that it's logarithmic, so that every time you see, you go from 7.4 to 7.3, 7.3 to 7.2, so on and so forth, that those changes have dramatic impacts on the ionization of the drug. Okay? So when I do that, I'm not looking at the slide, so I think I covered everything on the slide. Here's my next slide. So what are some of the undesired effects of local anesthetics? And I really should have, I thought I changed this to just effects. Desired, undesired, it all depends on what you want to do. So CNS, local anesthetics may cause CNS stimulation, producing restlessness, tremors that may progress to chronic convulsions. So one of the big problems is I have something that blocks sodium channels. Okay, great. I get a large concentration of it. And I've talked about this in the past. When we talk about what's going on within the CNS, the thing that we're most concerned about is when we eliminate or we block the ability to break, right? So I'm blocking all of this nerve activity going on. The one that has is most susceptible is that which is the break, that which balances and slows down activity. Because if you're still awake and moving, you have activity. So that means that if I was to change anything, I'm more than likely having the greatest impact on the inhibitory component, which if I block that, I wind up with seizures. Because now I have an overexcitement. Does that make sense? I've always got excitement going on. They may be able to temper some of that, but what I'm most worried about is if they temper the brake, if they temper the ability for the GABA or other inhibitory mechanisms to manage and or control the excitatory components. When that happens, then you can wind up with seizures.
So when you say the ability to brake, you mean the ability to stop what they just did?
So everything is about the braking accelerators, and you hear me use that reference in the CNS. Activity, excitement is the accelerator, right? How quickly, how carefully I'm able to reach out and touch and grab something requires a brake. My thought process, my mind could be going 1,000,000 miles a minute. If that happens, then I become anxious. I may not be able to focus. So what happens is that there's an inhibitory component that allows me to see one thing at a time instead of 10 things at a time. If I don't slow that down, that 10 can turn into 100, and I get this overstimulation. Overstimulation leads to,
Seizures.
yes. Make sense? Kind of.
Come back.
Okay. The more you say it, the more it'll start, you'll feel comfortable. And I truly mean that. Cardiovascular decreases in electrical excitability, conduction rate, force of contraction, in addition to vasodilation. Usually seen only after high systemic concentrations are attained and CNS symptoms are evident. You will use lidocaine, and lidocaine has been put back into the ACLS protocol. You guys, it was his second visit. I'm not happy with it because I don't like lidocaine for that. But what it does is that it can suppress it decreases the rate of rise of sodium in phase 0. How comfortable are you guys with your EKGs? Comfortable?
Absolutely.
So knowing what produces a deflection. Automaticity, right? You guys remember the term automaticity? All right. So the heart's able to beat all by itself, doesn't need any type of intervention. Innovation can speed it up or slow it down. Fantastic. When we think about automaticity, once you stimulate the cell and you generate that wave, that impulse that then results in contraction, what is responsible for the actual depolarization of the ventricles? And that is the sodium rushing in. So what can happen is I can change the slope. It's no longer really fast, it's kind of fast. Well, we would use lidocaine for very specific types of dysrhythmias. Those of the ventricle. And what it's used for is it's used really in individuals that have like post-MI, where they get these ectopic foci. So you get a beat that's being generated outside the normal conduction system. Okay? You guys remember those terms? Vaguely? Okay. We'll just keep it to the Pharm. So it decreases electrical excitability because it makes sure that it's only coming from those the normal cells that have automaticity. Can decrease conduction rate, again, only coming from the pathways within the heart, and because of that can decrease force of contraction. The big one here, vasodilation. You guys have heard me say this time and time again. Because of the increase in vasodilation, can you tell me what happens when I inject one of these local anesthetics into a local site? Because it's a vasodilator.
It can wash out the
It can wash out. So what do we typically add to it?
epi.
Wash out what? That
The actual local anesthetic.
Oh, right.
It's not saying it decreases vasodilation, right?
No.
Okay.
No, so it decreases
I got
this.
you.
And vasodilators. Yeah, sorry, that's my fault.
So you-
Just wanted to clarify.
You give epi to then produce vasoconstriction?
Yeah.
Okay.
Keep it in the area. Typically quick on, quick off. You know, some of those that have, that are more lipid soluble have a slower onset of action, means they'll have a longer duration of action. For those of you at the bedside, you'll use this for A-lines. So if you, or cut down procedures, when you see, you're trying to numb an area in order to cut or do an insertion, you know it's gonna be painful, they'll typically do a wheel in and around the area. So they'll do 2 or 3 injections with the lidocaine epi. What I'll tell you is this, have you ever seen it done? Have you ever seen A-lines put in?
Uh-huh. I just did this
Okay.
one.
So the patient was conscious or unconscious?
Fully awake.
Yeah. Not real pleasant, huh? Right. So if you're good, it's a one-time stick and you're done. Okay. What I was gonna say was, in order for it to numb the area up, you have to use 3 or 4 sticks, and it stings. So as you numb the area up, it's not pleasant either. Now, it lasts for a few seconds and goes away, but if I'm really good and I feel a good pulse and I'm pretty sure that this is where I can stick them, then I won't numb them up. I don't think I've ever used lidocaine prior to the insertion. I know a lot of people that do, but I never have. And I'm not gonna tell you my success rate because I don't want to use it. I'll just leave it at that. And I'll tell you too, the other thing too is that always visualize your anatomy, always. Use 2 fingers, you can tell the direction of the vessel, hit it down, and visualize your anatomy. All right, smooth muscle. Oh, okay, it's not misspelled. Press contractions in the intact bowel, which strips of isolated intestines, in addition to relaxing vascular bronchial smooth muscle. Any of the anesthetics, local, and as we talked to the inhale, one of the things it can do is it can shut down normal bowel movement. So what you'll always find is that, and this is much less common in the locals, but in the general anesthetics, they want to make sure you go to the bathroom before they discharge. They want to make sure that everything is moving.
So you said it could shut down what again?
What? No, okay. Just some examples of some of your topicals, EMLA cream or patch. It's a combination of local anesthetics, Ceticaine spray. So you may see this being used for bronchoscopies. You may see it used for TTEs for the initial insertion, in addition to several other medications. And in tissue injections, dental procedures, as well as sutures, they may use lidocaine. Okay. Kinetics, the core to the pharmacology. Uptake, speed of uptake is related to the degree of vascularization. So areas that are more perfused it's gonna wash out quicker. If you are working that area, okay, that's the other thing. If I'm pushing, I'm massaging, I'm flexing, I'm rubbing, you increase perfusion to that area. Distributions depend upon vascularization and rapidly absorbed. Biotransformation, the majority of these are the liver. Okay, metabolites can have serious side effects. We talked about cardiac and CNS. Excretion and clearance depend upon, again, circulation. The liver is for the drugs that we discussed and we use, is primarily cyclone P450. Systemic absorption, again, is dependent on site of injection, dose, physicochemical properties of the drug. So where is it? What is it? What's the pH? Should say that. It's the pKa. Okay, so pKa, and I'm going to just stop for 1 second and give it to you so that you understand when you hear pKa of a drug. If I say the pKa is 8, do you know what that means? Me either. I was hoping somebody might have Googled it. Maybe you can use ChatGPT and read off and it sounds like we all know what we're talking about? No? Okay, you're correct. The lower pKa is stronger than the acid. pKa is the pH at which it's 50-50. 50% ionized, 50% unionized. And then it's very important to know whether it's an acid or a base. I'm not gonna go into chemistry today because I saw the look,
Mhm.
right? I saw the look. But I'm gonna simply state that pKa 50-50, okay? That's the pH at which it's 50% ionized, 50% unionized. That's an important thing to know. I don't have it up there, but I have everybody in the room, so I can say that is an important thing to know what pKa is.
We don't need to know what it,
50.
it stands for.
No, I'm not gonna ask you that. It's just that it's 50% ionized, 50% unionized. Okay? And I'm gonna tie this back to what I originally said. So if you have a weak base, that means that as you go above that pH, it is unionized. As you go below it, it is ionized.
Say that one
For a
more time.
base, as you become more acidic, okay, relative to the pKa, it becomes unionized. I'm sorry, it becomes ionized. It becomes ionized. Lower pH, ionized. Lower pH, ionized. That's why they don't work in areas of infection. Lower pH relative to the pKa, ionized.
What do you mean relative to the pKa?
So what's pKa?
The 50%.
50-50, right?
Mhm.
So if my pH, it's the pH at which it is 50% ionized, 50% unionized. If my pH is less than the pKa, then that means I have more drug that is ionized, which means it's not effective. Cannot cross the cell membrane, cannot have the effect that you want. Does that make sense? And I'll stop with chemistry. I get a little excited about that. I actually had a whole session, an hour lecture just on pH and pKa and local anesthetics. It's fun. Well, it's only fun because you can manipulate the body, so you manipulate it. That's the reason why it's fun. I like to, anytime you can trick the body into doing something or trick a drug, then I get excited. All right, so Vivicaine and lidocaine are the ones that I absolutely want you to know, and EMLA show up as lidocaine product. Vivicaine, I want you to be aware of is that it is prolonged effects. Slower on, slower off, as opposed to lidocaine, which is quick on and quick off. That's what you have to be able to distinguish between the two. They're both local anesthetics, they both can work similarly. It's just that one is more lipophilic than the other. Okay?
You said which one was slow on and slow off?
Bupivacaine is slow on, slow off. So you're not gonna use it for those bedside procedures. But you could use it for something that's gonna take a little bit longer.
Would they call it still lidocaine?
No.
Like when they tell it to you?
The drug, yeah. They'll call it by the drug's name.
What would Novocaine be?
I don't know.
Novocaine. Is it one of those or is it just something
No,
else?
it's different. There's drugs in it, I don't, it's not commonly used anymore. We're gonna be looking that up right after class. Questions or comments to this? Bupivacaine is gonna be, it's more lipophilic, it's gonna be a slower onset, longer duration. Lidocaine is quicker on, quicker off. Yeah. Would that be? nothing, it's fine. They're just longer duration. Epi is there just, you're using epi in order to keep it at the site. You typically aren't gonna use Novocaine the same way. You're not gonna be using it for like these quick procedures. You don't want your mouth numb for hours, although that's what typically happens with the test. Because they load it up and the epi keeps it there, 2 or 3 hours later, but it's protection. The last one to talk about in this group is cocaine. Who does cocaine? So, a little bit about cocaine. It's a Schedule 2, it is not a Schedule 1. Because it has absolute addictive properties, but it actually has medicinal use, where Schedule 1 is highly addictive with no medicinal use. This has medicinal use. Mechanism of action, so this is what makes this unique. For those of you on the cardiovascular side, how often have you seen 20, 22-year-old individuals coming in with dilated cardiomyopathies? And they're on cocaine.
It's mainly IV drug users, which I guess could be cocaine from time to time, but they
Cocaine's
normally
one that's gonna-
opiates, guys.
The opiates are producing that?
Cardiomyopathies.
Okay, so this one does it a whole lot faster than your opiates. In time, again, maybe high doses. Problem with cocaine is that it has a couple of unique features. It inhibits voltage-gated sodium channels. So what does that make it?
An anesthetic.
An anesthetic, right? So you don't feel much. But this is where it really gets tricky. It blocks the reuptake of dopamine, noradrenaline, as well as serotonin. So when I am chasing a high, which of these is most important in chasing the high? Which one produces the addiction?
Dopamine.
Dopamine. So the euphoria can come from dopamine and serotonin, a little bit of the adrenaline. But really it's the dopamine that keeps driving me back. When I talk about it blocks the reuptake of dopamine, I use that as if I was saying hello, good morning. Do you understand what that means?
No.
Yeah, it just sits in it's not reabsorbed. It just sits up there in the space.
So for all these neurotransmitters, it takes a lot of energy to make new neurotransmitters. So what the body does is it releases it into the synaptic cleft, and it wants it back. So it goes in, and then you've got all of these little reuptake transporters that as it moves back and forth between the presynaptic and postsynaptic terminal, when it binds to the presynaptic, it gets scooped up and pulled back in, and then it gets repackaged into a vesicle, and it gets ready to be released. Okay? So by blocking the reuptake, it leaves it in the space for a longer period of time. Now there's other ways to metabolize these. There's, for those that are catecholamines or CORT, and there's a couple other ways to do it, but it takes a longer period of time. Most of our antidepressants, they're reuptake inhibitors. They block the reuptake because it's an imbalance, right? When we talk about certain CNS disorders, I might have too little norepinephrine and too much serotonin, so I want a drug that is specific to norepinephrine reuptake. So we can now target some of these neurotransmitters. We're not 100% sure of what causes it, but I hate to say it, that when they start you on these drugs, or you have family members that are on these drugs, they're guinea pigs. These are the ones that work the best, and we think that are have the highest success rate. If it doesn't, then they move you to maybe a slightly different class. But they should be asking questions to get a feel of what type of depression, anxiety you might be experiencing, because then it can selectively target those neurotransmitters. Some of the really bad drugs, which we're never going to talk about in this class, like MDMA, methamphetamine, specifically methamphetamine, they not only block the reuptake, but they also increase the release. So any neurotransmitter that does make it back into the terminal, It's like a sieve, just right back out. So very small releases of these neurotransmitters results in very large concentrations within the synaptic cleft. Okay? And those are much more highly addictive than other drugs. That's how norepinephrine, how cocaine works.
So you said blocking the reuptake does what? Blocking the
It
reuptake
leaves a
of-
neurotransmitter in there a longer period of time, and because of the ones that it targets, it produces euphoria. It can produce, it can also produce hyperactivity because of noradrenaline, and it increases the risk of addiction because of dopamine. That's what each one of those neurotransmitters up there does. Dopamine,
Blocking the release of
serotonin.
dopamine.
Sorry,
Blocking the release of dopamine.
reuptake.
Reuptake, yeah.
Addiction. Highly addictive, minimum development tolerance, currently used for topical anesthesia of upper respiratory tract, ophthalmic areas. You will see a lot of this for rhinoplasties. Do you know why? You know why they like it? So it does, because of the noradrenaline, okay, norepinephrine, you have, it blocks the pain, that's sodium channel blockers, and it vasoconstricts. This drug vasoconstricts, and that's why you see the cardiovascular problems. It's because it is a potent vasoconstrictor, right? It leads to acute increases in arterial pressure, tachycardia, often ventricular arrhythmias. So cocaine is bad. All right, general anesthesia. We're going to start with the couple brief overview. What we typically are trying to do, the 5 states or primary effects are unconsciousness, amnesia, analgesia, inhibition of autonomic reflexes, and skeletal muscle relaxation. So we're now moving to keeping somebody perfectly still. As we talked about those local anesthetics, you may not feel pain, but remember what I said. I said it's a continuum, right? So you start with the small nerve fibers. So it's the proprioreceptors and the small nociceptors, and then it graduates up to temperature, ultimately to motor reflexes, but that's higher concentrations, higher doses. When we start talking about general anesthesia, we don't want them to move. When you're trying to cut on somebody or you're trying to remove something and you've got nerves and other tissue in and around that area, you do not want them twitching. Not a good thing. You okay over there?
I'm doing great. I just threw my pen across the room.
Just making sure. So we talk about inhaled and intravenous. We're going to actually start. I flipped this morning as I was going through it. I thought it would be better to talk about intravenous first because it's more relevant to what you do. So I'll go through the inhaled a little quicker because most of you won't see the inhaled. It's just for completely safe. So when we talk about initiation of anesthesia, intubation, induction, maintenance, and emergence, okay? Typically, you don't talk about intubation. It's induction, maintenance, and emergence. I added intubation because I wanted to talk about it because you guys are going to see a lot of it. So, 2 classic drugs that you will see being used, succinylcholine or etomidate to intubate. Succinylcholine we're not going to talk about any other place today other than right here. So I'm just going to give you 1 or 2 pieces of information that are going to be very, very important that you remember. Is that it is a neuromuscular blocker. And that it is a depolarizing neuromuscular blocker. Succinylcholine is a depolarizing neuromuscular blocker. Can anybody tell me what that means?
I don't know, but I've seen like an episode of Forensic Files, and like she was giving her husband that, and I think he died. I don't know if anyone
Because
saw that
it blocks
episode.
all activity. What it does is it causes every single motor end plate to discharge.
Motor what?
Motor end plate. So every muscle, every muscle that can contract, it does. So what do you see when you give this to the patient?
Is that a form of seizing?
No. Every single muscle is depolarizing. And then it's blocked. So now they're paralyzed. So it's a paralytic. It's the only one I'm gonna talk about, and I put it up there as I don't have any other place to talk about these. I'm not gonna talk about rocuronium or any of these other ones that are paralytics, just succinylcholine. So it is a depolarizing paralytic.
So when I was in the ED, and they use etomidate to intubate somebody, but they also use the whole body.
I don't know. Rocuronium has a longer duration. Succinylcholine is much faster. They may have been, are they taking them to surgery? Like, are they intubating them and moving them to surgery? Did they have some type of major wound or problem somewhere that they had to, they were trying to address? So here's the other quick point with succinylcholine. They are awake. Completely awake. They hear, see, and feel everything. They just can't move. It targets the motor end plate, not the pain receptors. Motor end plate. You want to torture somebody? Give them succinylcholine.
Yeah, so what's the point of that?
They're paralyzed.
But why would you leave
You want somebody doing this when you try to stick a tube in?
Yes, no, but why would you even give that? Why wouldn't you give them the drug that allows them to forget if you're sticking a tube down their throat?
You do give it to them.
I'm confused.
That was my next statement.
Oh, okay.
So because of that, when you're using succinylcholine or rocuronium, what do you also have to give? Some type of benzo. You will never see them give it without.
Wasn't there a story about?
Yeah.
Okay.
Yeah, they had somebody go to surgery that was paralyzed
Yeah.
and was awake and felt the entire thing.
Yeah.
So they can feel it.
Yes, let me
Okay.
back up one more time. Motor end plate.
Motor and plate.
So it paralyzes the motor end plate, so I can't move. It does not affect the pain receptors. So I feel pain, but I cannot move.
So basically, you want to make sure that's always the last thing that you push through the IV.
Yeah.
And it only lasts 3 to 5 minutes?
Dude, how did you not die?
Yeah,
Like
from
going
pain?
through, I mean, maybe not pain specifically, but being in surgery, I feel like
Heart
when you
rate will
feel
go
that,
through the roof.
Exactly, like
Right.
all of the
So that's
mechanisms
called
start failing.
malpractice.
Yeah, write that down. 500K, right?
Yeah, it's a
Cap that one.
report, right?
I have a question. You know how sometimes they do brain surgery and they have to keep the patient awake? So would they give them something for the pain but keep them awake but give them this, or would they not be able to
They
talk?
can't give them that.
Okay.
They'll do spinal blocks.
Okay. You know what I'm talking about though, right?
Oh,
Like when
no,
they're asking
absolutely.
questions?
So they'll do blocks.
Okay.
Because they need to be able to talk to you. Can you
Okay.
please
So you can't talk
move a
with
finger,
this?
but
Okay.
they can't move this, right?
Okay.
So they're targeting very specific areas.
So you said the patient is given what with this drug?
Benzo, always, 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 always. So you stole my thunder.
So it only lasts 5 minutes.
It's very short. They have some patients that don't, they have problems metabolizing it. And if they can't metabolize it, then it lasts a long time. I'll just say more than half an hour. And I don't want to get into the specifics of that. It's a specific acetylcholinesterase difference. All right, so the intravenous anesthetic agents that we're going to talk about, we're not going to talk about benzos because we've already talked about them. I put them up there, the same ones that you've seen except alprazolam. These are the ones that you had to know prior to. These are in conjunction with or adjuvants, okay? They're given in combination with because they can reduce anxiety. We are going to talk about propofol. We're not going to talk about fentanyl. We're talking about etomidate and ketamine. So propofol, Michael Jackson drug. I say that, and I'm not being disrespectful, but I say that because it'll help you remember what the drug is, okay? So it's a milky white substance. Mechanism of action, positive modulation of the GABA, through GABA A receptor. I could get the little A to go there. Primary uses, most frequently used drug for induction of anesthesia. What does induction mean?
The start.
To start. So there are different phases. I'm inducing anesthesia, I'm maintaining anesthesia, and then I'm allowing you to emerge from anesthesia. Depending upon the amount, the dose, the infusion rate, I can control where you are with that anesthesia. It's called MAC. Managed anesthesia care. Sorry. So you were asking earlier about that, right? They give a drug and sometimes they've given too much and they have to bag them. Depending upon the individual, a certain dose of a drug may have a greater impact. If I'm trying to induce, I only give enough to where I knock them down. It doesn't have any analgesic properties. Right? What it does is it puts you to sleep. If I keep giving you more of the drug, I can knock you out completely. They don't like to use propofol for that. They just want to induce. And the reason is because it's got other side effects. They prefer the gases in order to maintain the anesthesia. Short term, where I want you to be able to cough, I want you to be able to swallow, propofol is great. Rapid onset antiemetic, what does that mean? I'm not going to throw up. The inhaled gases will absolutely make you nauseous. Okay? Will absolutely make you nauseous, and some of the other ones will make you nauseous as well, because they get within the blood. I'll just say they make you nauseous. Entirely, with all the details. Decreases cerebral metabolic rate and O2 consumption. So sometimes you'll see this used in neuro units with closed head injuries. They have more propofol. Okay? So some of the disadvantages, you can have allergic reactions, dose-dependent decreases in blood pressure, blunts the baroreceptor reflex, it is a respiratory depression, depressant, pain on injection. You see this in a very small percentage of people where you have propofol infusion syndrome. Okay? So what's important with this? Quick onset, quick offset. Does not cause nausea and vomiting, and depending upon the dose, can be used for induction or to fully to produce full anesthesia. Yes.
So for propofol infusion syndrome, you would assume it's not working in that case?
Oh, it's working. It's just an unusual impact on within the CNS.
Okay.
It's a rare disorder. They don't have a specific cause or reason for it.
So even though the pH is dropping, it's still.
Propofol's not, it's not a local anesthetic. It's not as pH dependent. That's your canes. Good distinction. Etomidate. I want to make sure you understand and you know etomidate. I like propofol and I like etomidate. I really like those two. I'll ask you questions about those because those are the ones you will most frequently see. No analgesic properties. Used for induction patients with cardiovascular problems because it has almost no cardiovascular effects. Does propofol have cardiovascular effects? Dose dependent. Okay? This doesn't. So we like this with when we intubate. They like to use this more than they like to use anything else for intubation purposes. So advantages, minimal hemodynamic effects, rapid induction, short duration, minimal respiratory depression. So you can tube them, get them on the vent, and then it's off. Disadvantages, you can have some pain, nausea, and vomiting. You gotta be aware of that. Can produce increased EEG activity in epileptic patients. So what that means is if you have a patient with epilepsy
don't use etomidate. Okay, that's why, you know what, I gave you a drug that they frequently use for epileptic patients. Actually, it was a class, I gave you benzos, but I also said that you could use phenobarbital. Okay.
You don't want to be using etomidate medications. I say that because these are the things that distinguish good versus bad care. Somebody comes in that's a cardiovascular patient, do you want to put them down with propofol, or do you want to put them down with etomidate? By the way, minimum cardiovascular.
So then why do, I feel like every patient that we go to in the ICU that's, going under for something, especially, I'm only seeing cardiac patients for the most part.
Propofol?
Always.
Well, because it's not an acute situation. So they're gonna put them down, they really don't care because in about 30 seconds they can be on gas, and they only give them enough propofol because it is what? Dose dependent. They're using it for induction, they're not using it for maintenance. So they initiate it and then come back with the gas and then the propofol is off. Within 5 to 10 minutes it's off, and I've got complete control over it.
You said epileptic patients can't have etomidate, and what
I didn't
else?
say they
That's
can't,
it.
I said you should be careful. You have other options. I'm telling you, I would. But it would be my call. Special K. Ketamine. Mechanism of action, non-competitive for NMDA, glutamate receptor antagonist, partial glutamate. It's dissociative. This is typically used for induction of anesthesia in at-risk patients with cardiovascular problems and bronchospasm, sedation or general anesthesia in children. Because it doesn't have, for long term, I don't want to be using necessarily propofol or etomidate. And they don't always like to use gas in children. So sometimes what they can do is they'll use ketamine throughout the entire procedure. Okay? So advantages, cardiovascular stimulants, so you've got to be careful of that. It's a bronchodilator, profound analgesia and amnesia, potential uses in depression. This is, if you ever hear about ketamine being used outside as opposed to an anesthetic, analgesic, it's for depression. Okay? Disadvantages, increase in cranial pressures and increases myocardial oxygen consumption. So ketamine in a cardiovascular patient, not so good. All right, so the last thing that I'm going to touch on and talk to today is going to be inhaled anesthetics. This is the takeaway from this. I'll ask you 2 questions for the last 4 slides. Okay, that'll be it. So look for those 4 questions and what that might look like. Minimum alveolar concentration is 1.
Wait, what did you say?
I'll only ask you 2 questions on the upcoming exam for the next 3 slides, 4 slides. How many slides left? 3? 5? So for the next 5, I'll only ask you 2 questions. I'll be very direct. Because you're not going to encounter this much. But I do want you to understand what minimum alveolar concentration is, because it has to do with why they will use combination of drugs. 1 MAC of inhaled anesthetic is the alveolar concentration that prevents movement in 50% of patients. Okay? So 1 MAC minimum is 50 movement in 50%. So you're always targeting at least 1 MAC. Different drugs require a different percentage in order to produce that MAC. So the example I gave you here is if I'm using nitrous oxide, 53% of the inhaled gas of nitric oxide produces a 0.5 MAC. Why can I not use 100% nitric oxide to produce general anesthesia? How much nitric oxide would it require to produce 1 MAC?
Over 100.
Over 100. It would require 106% to produce 1 MAC.
that make sense?
So it's always used in combination of.
Nitrous oxide, yes. Other ones, I'll show you in a minute, takes very little, right? We don't use halogen, but I use this as an example. But we do use isoflurane and sevoflurane. 1 MAC of isoflurane is only 1.2%. That means the rest can be oxygen and nitrogen and anything else you want. So it requires very, very little isoflurane for 1 MAC. But it has side effects, so that's why you use these combinations. Factors affecting alveolar concentration: the greater the uptake of the anesthetic agent, the greater the difference between inspired and alveolar concentrations. That means that more is being absorbed into the blood. So high solubility is a slow induction because it is not staying where it needs to be. It's being spread out. Advantages and disadvantages. Advantages include bronchodilation, dose-dependent decrease in skeletal and smooth muscle, decrease in cerebral metabolic rate, increase in cerebral blood flow because of vasodilation. Disadvantages are the things that you want for it, right? Respiratory depression, you're going to control it with a vent. Myocardial depression, got to be careful. Oftentimes, these individuals, you will see them come out full of fluid because it will give fluid in order to try and maintain the cardiac output and their blood pressure because of the vasodilation. Has anyone ever seen anybody come out of surgery and they look like they're all ballooned up? It's because of this. Increased risk of nausea and vomiting, risk of emergent delirium as they come out, and then there's risk of malignant hypothermia. So when they do have or see malignant hypothermia, where you see a spike in temperature, it's because of excessive calcium release. Use dantrolene. And this is a summary of the max for each one. So you see isoflurane and sevoflurane, desoflurane, nitrous oxide. I think I gave you some examples of why you use each one. We don't like isoflurane because of the smell. So you would have to induce the patient prior to using isoflurane. It's got a terrible smell. They do like sevoflurane. It's probably the one that's most frequently used. If we're worried about cardiovascular problems, then what we'll do is that we'll add some nitrous oxide. So we'll add nitrous oxide with sevoflurane in order to reduce the amount of sevoflurane that's needed. Okay? I see a headache coming out over here. I saw the expression.
Oh, I didn't hear the last thing you said. but-
Oh, so to reduce some of the cardiovascular effect of these, sometimes what we'll do is we'll add nitrous oxide. Because nitrous oxide has little to no cardiovascular